It's Friday, the 4th of July, and this is the Hot Topics Podcast. Welcome to the Hot Topics Podcast. Thanks for joining us once again, everyone. Neal Tucker here to take us through the next 20 minutes or so on what's new in the medical research relevant to us working in general practice. 3 papers to talk about today, 2 from this month's BJGP, which is crammed full of clinical gems. So we're going to have a look at one paper that has a look at how good a couple of different medications are for managing insomnia. Then a second paper looking at some of the potential side effects, specifically postural hypertension linked to starting anti-depressants. And then we're going to round up with a paper in the New England Journal of Medicine, which I'm going to be honest is not hugely relevant to us in general practice at the moment because it's about a chemotherapy agent, or I should probably rephrase that, some new cancer agent that isn't chemotherapy, which just blew my mind and I thought it was worth sharing. Talking about sharing, just to keep you in the picture of what's going on with NB Medical at the moment, we're running our last live webinar before the summer. That's on tomorrow, Saturday, the 5th of July. That's our fantastic cardiology and ECG course. If you can't make it, don't worry. You can always watch it on demand. If you want to upskill in ECGs and know lots more about cardiovascular disease, that is the place to go. After that, we'll be taking a little hiatus over the summer, and then we'll be back with all of our courses online from September. Don't worry, if you want to catch up with stuff over the summer, all of it's available on demand as well. If you subscribe to MB Plus, you can watch all of it for just over £300 a year. As good as our online offering is, and it's really good, some of you I know love to do the face-to-face courses. I love to do the face-to-face courses as well. So we're reintroducing them in September. We'll be doing 2 dates in London for our key hot topics course. If you're interested, do check that out. Do book up. I really hope that it's popular, it's successful, because I'd really love for us to start doing more and more of these around the country. Lots going on in the medical news over the last week, way beyond my pay grade. So we've got a new 10-year NHS plan. What I love about this new 10-year plan is that it sounds like someone mansplaining all the things that general practice already does. There'll be same-day GP appointments for those who need it. They'll get a telephone or digital consultation on the same day they request it. That sounds worse than what most of us are doing at the moment. They not realise that we already do that. There's some stuff that suspiciously sounds like PCNs but has been rebranded. There's some stuff that sounds suspiciously like community hospitals but has been rebranded. They conveniently forgot that a few years ago they tried to shut most of them down because it's better to do it all in the hospital. Really, the only difference is that they're saying outpatients will be outside of the hospital. This is, of course, a very important move to free up space in hospitals because that's going to be needed for all the old senile ladies who are bed blocking because the government forgot to do anything about social care. Meanwhile, there's lots of talks about new contracts, and the BMA is concerned that this represents an existential threat to general practice. However, they've decided to word these contracts means that hospitals might end up running GP practices, which, given the fact that hospitals are often not running hospitals very well, why you would want them to take over general practice, which generally is run quite well, is a bit beyond me. And while we're on the subject of shite ideas, Labour's trying to bring back PPP, public-private partnerships. Because, of course, these worked out so well last time the Labour government introduced them, virtually bankrupting large parts of the NHS. Hard to know really what, in all the discussion around this, most closely resembles the truth, and God knows I am no expert in these areas, but if there was the option for me between helping GPs buy and run their own premises, brackets, and allowing them to cash in the profit at the end of their careers having done that, close brackets, or giving the cash to a private company who is likely to build on the cheap, overcharge rent for 30 years and then rip you off every time you need to change a light bulb, well, I'd probably take the GP option, who are quite capable of changing their own light bulbs for free and will do it today rather than in 4 weeks' time. Now, enough about the news, because mostly it just makes me angry. Let's move on to the research, which generally makes me happy. So first paper of the day in this month's edition of the BJGP has the title Effectiveness of Low-Dose Amitriptyline and Mirtazapine in Patients with Insomnia Disorder and Sleep Maintenance Problems. This is a randomized, double-blind, placebo-controlled trial in general practice with the catchy acronym DREAMING. It's the DREAMING trial. Now, I couldn't work out from the title and the letters how on earth they came up with that. This is a study from the Netherlands, so I presume there was something lost in translation. But actually, when you go down to the methodology of in the paper, it says that actually the title is Drug Rediscovery, Low-Dose Amitriptyline and Mirtazapine for Insomnia Disorder in General Practice, which does, if you get the right letters in the right order, spell dreaming. Well done them. But of course, insomnia is a serious issue. It's something that dramatically affects people's quality of life. You only have to do a few days in general practice to have various consultations with people about their lack of sleep, their exhaustion, their stress over not being able to sleep, and getting themselves into these vicious spirals where that concern around not sleeping then prevents them sleeping, and it all ends up in a bit of a mess. That's why people book a consultation with us. And as the paper points out, and as we all know, the first-line treatment for insomnia is cognitive behavioural for insomnia, CBTI. And that would be great if we had really good access for it. And there seemed to be this halcyon phase a few years ago where there was NHS-funded online therapy for CBTI, Sleepio and the like. We had Sleepio for a bit where I am, then it got replaced by something else that I forget the name of. Now it seems to have disappeared off the face of the earth, and the local talking therapy services provided on the NHS don't seem to provide an easy option at all for any of our patients. So, of course, then patients and us are turning to alternatives. Back in the day, we just whack them on some benzos. Then, of course, we realised that wasn't so great. And as we've reduced benzo prescribing for insomnia, we've been replacing it with other things, namely pretty much anything that might make people tired as a side effect. And amitriptyline and mirtazapine have become two quite widely prescribed alternatives. This is one of those pragmatic general practice things that we often do because there's definitely a lack of evidence base supporting these treatments in the management of insomnia. And that's what this paper is trying to address. So this is a pragmatic, double-blind, randomized, placebo-controlled trial undertaken in general practices in Amsterdam and thereabouts. So the authors recruited patients aged 18 to 85 with insomnia disorder and sleep maintenance problems. They'd tried non-pharmacological treatment, and that was insufficient to improve their problem. And then they were randomized to one of three groups. So either mirtazapine, 7.5 to 15 milligrams a day, so fairly low dose, or amitriptyline, 10 to 20 milligrams a day, or placebo. And they had that for 16 weeks. And at the start, they measured the degree of their insomnia and the problems that was causing with them using the Insomnia Severity Index. So that's scored from 0 to 28. And then they measured that again at 6, 12, 20, and 52 weeks. That 6-week mark was important, though, because that's their primary outcome. So looking at that Insomnia Severity Index at 6 weeks to see if people have had a clinically meaningful improvement. So that would be more than 7 points change from their baseline. And if they get more than 10, so it improves by more than 10, then that is classed as recovery. 80 patients were included, and this is a story of good and bad news, I think, because at the 6-week mark, mirtazapine had led to a statistically significant and clinically relevant improvement in insomnia, whereas amitriptyline unfortunately did not. In the placebo group, 14% of people met the criteria for improvement in insomnia and recovery of insomnia. In the mirtazapine group, it was 52% for improvement and 56% for recovery, which is much, much better. Amitriptyline actually wasn't far off at 40% and 36% respectively, but that didn't meet statistical significance. It wasn't felt that that was clinically relevant. However, you do wonder whether that's because the study's underpowered. It's only got 80 people, and as the authors acknowledge, it is a small sample size. My take on this is that both mirtazapine and amitriptyline seem better than placebo at getting people to have what they would consider for themselves to be meaningful improvements in their sleep. So far, I know what you're thinking. This all sounds like good news, Neal. We've actually got a treatment that legitimately looks like it might help people with insomnia that we can easily prescribe and doesn't cost the earth. So where's the bad news? Well, the bad news is that when they kept on following up the patients from 12 weeks onwards, there is no difference between placebo, mirtazapine and amitriptyline. The reason being that a large amount of people on placebo actually were better at that 3-month mark. So 52% improved and 45% recovered. In a way, I think this is actually good news as well. So about half of our patients, irrespective of what we do, are going to get better. Although I shouldn't fall into the trap of thinking that taking placebo is the same as doing nothing. And that is one of these things that often, I think, frustrates me with evidence-based medicine, randomized controlled trials, and using placebos. What we can say is, in this study, at 12 weeks, mirtazapine and amitriptyline are no more effective at improving people's insomnia than placebo. But what we can't say is whether amitriptyline or mirtazapine are any better at improving insomnia compared with nothing at all. And of course, you and I cannot prescribe placebos. In any case, what we can say, and what the authors conclude, is that compared with placebo, mirtazapine provides a statistically and clinically relevant reduction in insomnia at 6 weeks, supporting a role for it in short-term use, but not for longer-term prescribing. I think there are still lots of questions here. So what about patients that we've decided to avoid medication with? And ideally, we wouldn't prescribe medication for anyone with insomnia. But what if it's been 3 months and they're still really struggling? Is there then a role for trying them on mirtazapine or perhaps amitriptyline, perhaps for short, perhaps for longer term prescribing? And I guess the answer is we just don't know. And the other thing that I would love to know is, what if we took 2 groups of patients with insomnia, and one we just did usual care, which is having a chat with them, giving them a pat on the back and hoping for the best, and the other we gave a placebo to. Be really interested to see what the outcomes compared with those 2 groups are. Would the recovery rates at 12 weeks be the same there? There certainly is an irony here, because normally it's me taking the mick out of researchers saying that more research is required. But on this occasion, I'm the one saying it. I'm under no illusions whatsoever that this is actually going to make any difference whatsoever. On to our second paper from the BJGP, and I spent quite a lot of my time talking to older patients who are a bit dizzy or a bit lightheaded, and then also quite a lot of older patients who are a bit sad, and both of those issues meet in this paper. Now, of course, there's lots of causes of postural hypertension, but you and I are probably thinking about them most often in the context of medications. Antihypertensives, diuretics, alpha blockers, Parkinson's meds, all of these are commonly associated with postural hypotension. Also, you might think, given we prescribe a lot of amitriptyline these days, tricyclic antidepressants can do it too. But what about other antidepressants? Could they have an effect driving their blood pressure down? So this was a UK piece of research pulling data out of our UK primary care databases, a self-controlled case series. They looked at over 2.5 million people over the age of 60 as their eligible source population, and 2%, so 41,000 people, had a first recorded diagnosis of postural hypertension within their observation period. And within that group, a surprisingly high number of people had had a first recorded antidepressant prescription. So 20% had a tricyclic, 22% had their first recorded SSRI prescription, and 11% had another antidepressant. Now, it is true that those prescriptions weren't necessarily going to be for depression, but it seems like a really high number of people with postural hypertension also seem to have depression. And as it turns out, the authors explain that postural hypertension is an independent risk factor for depression. Who knew? Onto the results. And the short answer is that all antidepressants increase the risk of postural hypertension within the first 28 days of use. After 28 days, that risk diminishes and goes back to pretty close to baseline. The big surprise here is that it's not the tricyclic antidepressants that actually increase the risk the most. So they're associated with around a doubling of risk of developing postural hypertension in that 28-day period. The biggest risk comes with SSRIs. They're linked with more than a 4 times increase in the rate of postural hypertension. Other antidepressants, so that includes things like mirtazapine, venlafaxine, duloxetine, they demonstrate a similar risk increase to the tricyclics. The authors conclude that a statistically substantial increased risk of postural hypertension was observed with all antidepressants in the first month, particularly SSRIs, and that prescribers should be aware of this risk and may consider monitoring for postural hypotension when initiating antidepressants in older adults. I think this is a really nice study. I think it looks at something that's really clinically meaningful. I guess my only criticism, or perhaps frustration rather, it's not really a criticism, and I think it's probably linked to the style of data that they can report on, but it doesn't make it easy for us to understand what's the numbers needed to harm here. What's the percentage chance that if I start this medication in someone that they're going to develop postural hypertension? Because that's going to be much more useful information when we're sort of understanding or trying to understand the individual risks for our patients. Nevertheless, the authors do discuss the implications for practice. And what they're not saying is that older patients shouldn't be prescribed antidepressants, as they acknowledge late life depression is common. And we're always weighing the pros and cons of antidepressant prescription. This new research just maybe makes us a little bit more aware about the risk of postural hypotension and consider that as part of that risk-benefit analysis. So are they a high-risk patient, for example? Do they have Parkinson's? Are they on lots of antihypertensives? If they are already at increased risk of postural hypotension, is there an alternative to the antidepressants that we might be considering? And if there's not, perhaps this is an opportunity for us to put in a little bit more monitoring, a little bit closer follow-up with those patients, making sure they really understand the symptoms and signs of postural hypertension so they can flag it up with us if it becomes a problem. Perhaps there's something else that we can do either in their existing medications or day-to-day life that might mitigate some of the problem. Now, for my third piece of research this week, I was thinking about talking about a BMJ paper that's just published. It's on QOF, and basically it seems to show that QOF is essentially pointless. In their systematic review, they demonstrated that in the first year after the introduction of a new quality care marker, that did show improvements in that quality of care. However, by 3 years after introduction, the impact was inconsistent and not clearly better than pre-incentivization trends, as in we were all getting better anyway, and after a few years, it probably comes out about the same. Long-term listeners to the podcast will know that while I'm not necessarily a huge advocate of QOF, I have wondered in the past if we didn't have QOF, would we be anywhere near as good at treating blood pressure, diabetes, cholesterol, and so forth? This data seems to suggest that I need to wonder no more, that with or without QOF, we'd all end up in pretty much the same place. Perhaps then, if the NHS in England could follow the NHS in Scotland and just scrap QOF, perhaps if they just gave practices the money and then funded everyone to come on a hot topics course on an annual basis, given that most of us want to do the best that we can for our patients based on the best possible data, the most up-to-date research and guidelines, well, that's it. Maybe we don't need QOF at all. So that is important research, but all of that kind of stuff just leaves me feeling a bit depressed. So I want to leave us on an upbeat note. So we're going to talk about cancer. Having had a family member recently diagnosed with cancer, I've become painfully aware with how behind and out of touch I am with modern cancer treatments. There's a huge range of options. Those options are used in very specific combinations, no longer just dependent on the site of the cancer, but also the genetic type of it as well. Week after week, I see reports in all the major journals about new cancer medications, and often they seem to maybe only give a few extra weeks of life compared with conventional treatments for whatever cancer that they're treating. But every now and again, you see something that represents a really significant breakthrough. And that's what's just been published a couple of weeks ago in the New England Journal of Medicine. This is a paper called Non-Operative Management of Mismatch Repair Deficient Tumours. Normally, I don't even really look at these papers. They're a bit too niche for us. They're not that relevant to general practice. But this one caught my eye because I know on the latest Hot Topics course, we've been talking a lot about Lynch syndrome. And Lynch syndrome is associated with these mismatch repair genes. If you've got Lynch, you've got a really high chance of developing colorectal cancer. You can improve on that a little bit or improve your survival by having surveillance. And we've got data that shows that aspirin can reduce your risk, but still it can't eliminate that risk. So people might be really, really pleased to see this paper. As the authors explain, mismatch repair deficient tumours are highly sensitive to immune checkpoint blockade. Okay, so fair enough. I don't really know what they're talking about even by this point. Essentially, this type of treatment has already been shown to be effective in treating rectal cancers. In fact, not just treating them, resulting in complete elimination of them. And so in this study, they've then expanded this to look whether it could be an effective treatment for all early stage mismatch repair gene-related solid tumours regardless of tumour site. And that's important because it represents 2 to 3% of all solid tumours. So this was an earlier phase study than I would normally talk about on the podcast. This is a phase 2 study looking at patients who had cancers that were amenable to curative intent surgery, so stage 1, 2, or 3 solid tumours with this mismatch repair deficiency, and they were given dostarlimab, a treatment with one of the best titles they've ever come across, a programmed cell death 1 blocking agent. So they were given that for 6 months instead of surgery, and then they were followed up for their response. Out of 103 patients, 84 of them had a clinical complete response. 82 of them did not need to undergo surgery. Recurrence-free survival at 2 years, so they haven't obviously been following this up for like many years yet, but recurrence-free survival at 2 years was 92%. This has just blown my mind. So for these patients with this type of cancer, almost all of them have had complete resolution of their cancer just through giving them this treatment for 6 months. I think this is absolutely amazing. This just goes to show what medicine can do sometimes. Good news as well that the side effect profile seems pretty good. So most people only getting minor or no side effects at all. Sure, bigger studies are going to be needed, but this is a real window into the future of managing cancer. And as long as companies are prepared to make it affordable, the future is really looking pretty good. Okay, that's it for the research today. Thanks so much for joining us on the Hot Topics podcast from MB Medical once again. Do check out the mbmedical.com website to see all the things that are coming up over the next few months. Remember, you can always get in touch. Email is hottopics@nbmedical.com, or find us on Facebook and on X and maybe other places that the office haven't told me that we've got social media. And regardless, I'll be back in 4 weeks' time. Look after yourselves, everyone. Bye-bye.